Engaging vulnerable populations breakout session. This session is going to be just a little bit under 1 hour long since we're getting a little bit of a late start. It's going to be led by Mr. David Hendrickson and Dr. Tim Johnson. Mr. Hendrickson is the Regional Assistant Operations Officer at Intermountain Healthcare in Salt Lake City. So he's responsible for the productivity, budget, and patient care of roughly 260 staff, 74 providers, and 18 clinics. In his time at Intermountain, he has helped to implement and design a new high-risk, high-cost patient clinic that focuses on the top 5 to 10% of cost drivers in the system, and he's worked on a number of programs aimed at improving the quality and efficiency of the Intermountain delivery system. Dr. Johnson is a board member and the current medical director of Intermountain Medical Group in the Central Salt Lake region, and has worked with Mr. Hendrickson on programs to identify and engage complex patient populations. Dr. Johnson received his medical degree from the University of Utah School of Medicine and completed his residency at the University of Rochester Medical Center in New York. Please join me in welcoming Mr. David Hendrickson and Dr. Tim Johnson.
Well, I'm Tim, and this is Dave. So I know she was reading about us, but you don't know which one is which. So we have about 40 minutes, 45 minutes of presentation, but we left 15 to 20 minutes for questions at the end, and hopefully there'll be some questions. As we sat here listening to the session with all the leaders up here, Dave and I were commenting to ourselves that we have some challenges. And so hopefully some of the ideas we share with you today you may be able to incorporate and use in your own practices. So we're going to talk about something called the Personalized Care Clinic, which, as was mentioned, focuses on our patients who basically are the top utilizers in the system. And we'll go through that. I would also say that although there will be questions at the end, if you have a question right in the middle of the presentation, just stop us. We don't mind. We're informal like that. So hopefully at the end, you're going to have a better understanding of the new model of healthcare being implemented at Intermountain to help with our complex patients. And then kind of describe what we're doing. There's not a test at the end, though, so you can just relax. We wanted to start by giving you a little bit of a history of Intermountain Healthcare, because as we talk about the model we put together for our most complex, high-cost patients, I think you have to understand where we come from as a system. So Intermountain actually started in 1975. The Church of Jesus Christ of Latter-day Saints owned 15 hospitals in the state of Utah. And around 1974, 1975, they decided that really wasn't part of their mission or what they were about. So they were trying to figure out what they were going to do with these hospitals. And there were several large healthcare systems that came in and wanted to actually purchase these 15 hospitals. But ultimately, when it came down to it, they decided they'd take these 15 hospitals and just donate them as a gift to the community. And really, after they donated them, they put together a community board of trustees. So this is a board of trustees that they're not paid. And they, to this day, are made up of community leaders. About a third of them are physician leaders, and the other 2/3 are business leaders. And the other charge they were given is, they wanted Intermountain to be kind of provide. Okay, there you go. Just keeping them awake. Really, they said, we want you to be a model health system, and we want you to provide the best quality care at the lowest possible cost. And when the board was put together, that was the charge they were given. Whatever you do, remember you're focusing on the community, what's good for the community, how can we provide the best quality care at the lowest possible cost. So that started in 1975. In the early 1980s, there was some insurance products that were being introduced into Utah that were starting to drive up costs. And so the Board of Trustees at that point made the decision to actually put together their own insurance, which was called IHC Health Plans. It's now Select Health. Once again, that was an effort to keep costs down. And then in 1994, as part of the mission, Intermountain decided it was important to actually employ physicians so that we could become a fully integrated system. And you'll see why that's important as we talk about the particular clinic and the details of that clinic. But as a fully integrated system, as you can imagine, it's a little easier to make decisions that are great for patients. Because if you make a decision in a hospital that actually decreases revenue, may increase revenue for the insurance. So it all kind of washes out when you're fully integrated. And one of the nice things by having an insurance arm to Intermountain Healthcare is, we have data. So our insurance Select Health will provide the providers and the hospitals with data. We're not kind of fighting to get that data. So.
One piece of clarification: we are not a fully capitated HMO product. So, Select Health makes up probably 30% of the payer mix for the hospitals and clinics that work in Intermountain Healthcare.
We talked a little bit about this. So our mission, helping people live the healthiest lives possible, and envision to be a model health system by providing extraordinary care and superior service at an affordable cost. So a little bit about the medical group. So the clinic we're going to talk about actually is run by the medical group. But the medical group is a little over 1,100 physicians. You kind of see the breakdown there. We do employ a bunch of advanced practice clinicians, PAs, NPs, nurse midwives, and then the total number of employees. And if you're familiar with the geography of Utah, which I don't know why you would be, but although you should come visit, because the national parks in Utah are amazing. So we're spread up and down the state of Utah, but most, I don't know if I have a pointer on here, but most of the population is around Salt Lake City. So the Salt Lake Valley, where this clinic is about 1.3 million, 1.2 million. And then the rest is kind of spread out. The southern half is really rural. So we have 165 primary or specialty care clinics. I don't need to read the rest. You can just kind of take a look.
Care is our version of urgent care.
Is that just the care version?
On your previous slide, you referred to secondary providers.
Yes.
What would be the specialty?
Yeah, so that's like cardiology or urology or, that type of thing.
I'm not sure the cardiologist would call secondary.
Maybe that's good for them. That's the time of practicing internists, right? So, like most people, I guess like most states, we are working on how do we take care of our most difficult patients. And we found that in Intermountain there are a lot of patients that just need more support in a traditional primary care clinic. So as of this year, 100% of the medical group's primary care clinics are medical homes. So those medical homes where you have, psychologists come in and provide some support, you have health advocates, care managers, and that's what we call kind of the distributed model. That's everywhere. So every one of our primary care clinics is a full medical home. But at the same time, we realize that there are patients that even in the medical home are just way too complex. So the patient that I see on my schedule, and I see their books for 30 minutes, and I still know I'm going to be running behind when I'm done. And it's not because they're not great people. They're just incredibly challenging. Sometimes there are medical issues, sometimes there are psychological issues. Most of the time they're combined. And these are patients that if we looked at the system, were costing us a lot of money and really weren't getting the care they needed. So they were hurting themselves because they weren't getting the care they needed, and they were hurting the system because from a financial perspective, they were just driving costs up. So that's why we came up with the idea of a personalized care clinic or a more comprehensive clinic. The other thing we realize is sometimes we sit down and we talk with our patients, especially these complex ones, and we think we're communicating with them. We spend 30 minutes, and I'm like, okay, I'm pretty certain they understand why it's important for them to take their diabetic medicine, or why it's important to exercise, or whatever we talked about. And then they come back the next time, and it's like we've never had the conversation. So that reminded me of a little video I saw online. Now, it's really grainy, so you can forgive the video, but I think you'll see what I mean.
Das hier ist ein Mindset. Das hier ist das wichtigste Gerät des Wissens. Das Überlebensradar.
Hello? This is the German Coast Guard.
We're thinking.
what are you thinking about?
So sometimes we're like that, right? So we think we're communicating clearly, and clearly we're not communicating. So anyway, so personalized care clinic. I want to go over some of the kind of the basics of this, of how we put it together, and then Dave's going to kind of get into the weeds a little bit and give you more specifics. But personalized care clinic, I'm still on. Focuses on patients who are the top 5 to 10% of cost for 2 out of the last 3 years. Part of the reason we didn't just say the last year or 2 years is, you do have patients that for whatever reason had some type of catastrophic medical event that really aren't that complex. They just something really bad happened to them and their cost was more. But we figured that if we picked 2 out of the last 3 years, it's a little unlikely that someone who just had 1 or maybe even 2 bad events in a 6-month period is going to fall into that. So we picked 2 out.
And one of those years had to be 2013, so the last year. It's a rolling 12 months, so that's kind of how it captures the data.
So they're ranked on an algorithm, and Dave will go over that algorithm in terms of cost. And then, like I mentioned, they have multiple complex chronic health, social, and psychological conditions. And then the other thing that was important for us is that when we started this, we decided we were just going to focus on patients for whom Intermountain had full financial risk. So these are all the patients that are on the Select Health panels. We do have a Medicare Advantage plan. But also in this full risk model, we consider our uninsured as full risk. Because in effect, they're not going to be not-for-profit. When they come into our emergency rooms, we're full risk for that. Right? We do get a per member per month for those patients. It's 0. Right? So we take full risk for that. So they're also included in this patient population. We decided in Salt Lake City, kind of the mothership for Intermountain is this Intermountain Medical Center. And we actually decided to open the clinic on that particular campus. We thought a lot about this. Because in many cases, and in almost every other case, we want our primary care clinics off the hospital campus. But we made this decision for a couple of reasons. One, from a transportation issue, or transportation reason, there in Salt Lake City it's called tracks, so this kind of a light rail system. It goes right by the main hospital. And so it's a way that, if somebody was having trouble getting into a clinic and they couldn't drive or couldn't afford a taxi or whatnot, they could use tracks, which would be significantly cheaper. The other idea was these patients were very complex. A lot of the services they need are already on the Intermountain Medical Center campus. So maybe a little non-traditional way to think about where to put one of these clinics, but we decided to put it in the hospital itself. And then we opened February 3rd of this year. And Dave will talk about some of those outcomes. So this is the team. We look at the personalized care clinic, or the team there, kind of like the medical home on steroids. So we actually had 2 internal medicine physicians. For the first 6 months, we just had 1, and then at the end of September, we had our second one join, which allows us to see more patients, which we're happy about. We have a palliative care physician that comes in and spends some time in the clinic. We have 1 PA, a care manager. We have a psych APRN, she's there half-time. 2 licensed clinical social workers. So one of the licensed clinical social workers actually helps with some of the counseling, because kind of the psychological component. The other licensed clinical social worker actually helps us with our social work needs, and community resources and finances. We do have a pharmacist that's there full-time. We have a certified diabetic educator to come work with our diabetics. It says 4 medical assistants. We actually determined that's not enough, so we are in the process of hiring a 5th. We just had a meeting with the 2 internists about a week ago, and so how's it going? Do you have enough staff? And one of the clear feedback we got from our 2 internists, we actually need more help. Because the medical assistants are also kind of the health advocates, so they asked another medical assistant, so we are in the process of doing that. Then there's a front office staff, and a clinic manager. It's a process of care. So it does function like a primary care office. So they, in effect, for the time that they're there in the clinic, that's their primary care setting. They just have a lot more resources than even the medical homes. And then really they are ensuring that patients receive the care where they're supposed to receive care. There have been numerous stories, and we'll have to have a couple of patient stories at the end, but numerous stories of patients who would have gone to ER or an intensive care setting, but they were able to call and get in and actually be seen in that clinic, and kind of avoided those higher cost settings. They definitely collaborate with all the other specialists. So these are patients sometimes they're not so good about actually making their appointments or understanding that they need to be here and there. So the care manager or the health advocate will actually kind of navigate those waters for them.
And call and remind them and say, hey, you have an appointment with a nephrologist tomorrow. Do you have transportation? Are you able to get there? It's important that you be there. It's critical to your health. I mean, they'll call and follow up and do that work, which normally wouldn't happen in many of our offices. So.
Right. Yeah. I mean, you know this, but your primary care offices don't have that bandwidth. Right? I mean, there's only so much you can do. So, and then the last bullet here: committed to eliminating all avoidable healthcare emergencies. So we know that even in this patient population, even if we do a really, really good job, people are going to end up in the ER or have hospitalizations, and that's okay. We can avoid that if I can.
You know, by federal law, if a person shows up in an emergency room and looking for care, if by law, they have to provide care, are your ERs on campus able to say, you know, or recognize that this individual is part of your clinic and refer them over? Because I think that that's often a hurdle when we see individuals come in with something that is not an emergent visit, and being able to say, oh, the clinic is right around the corner. Are you able to do that?
I'll let Dave answer that easy question.
We do for some. So some of our really highest quote-unquote frequent flyers, right? The emergency department knows who they are. In the Salt Lake Valley, though, we have, 13 emergency departments, right? So it's not all coordinated. Some of those are not Intermountain emergency departments. So when they go to ours, they are flagged. They will triage them, make sure that everything's okay and reasonable and meeting EMTALA guidelines. But afterwards, say, why don't we give you a call and call the clinic and see if we can get them in the same day. So we do that.
And the interaction with primary care clinics. So as I mentioned, I'm a primary care doctor myself, an internist. And Dave will go talk about the process of picking these patients. But one of the things that we were concerned about as primary care doctors, actually I take that back, I was not concerned about it. Some primary care doctors were concerned they were going to lose patients and they were never going to come back. And really kind of a silly concern because we're all part of the same system. But and these patients, when they gave me my list of patients to look at, say, hey, listen, do you think these patients meet criteria? What do you think? Would you be willing to actually kind of turn over care for a few months to the personalized care clinic? I was like, woo, absolutely. So, but it was a little bit of a transition. So initially, when we started this process, I had a few patients that felt like I was abandoning them, and I had to actually talk them through that. Say, listen, we're still part of the same team, and Dr. Truding and Dr. Hendler, they're my colleagues. They're going to take care of you for six or 9 months, whatever it takes to kind of get you back on your feet, and you're still mine. You come and see me whenever you want to, and when you want to leave that clinic, great. But most of them, I actually did have one patient after about 6 months said, okay, I've had enough of that clinic, I want to come back. And that was fine, right? Because it really is an open door. So you had to have that conversation with the patients, otherwise they were sometimes getting the wrong idea. The care managers who were having most of these conversations about the transitions, they also learned kind of that jargon or that conversation as well, because patients were a little worried they were getting kicked out, and that wasn't the case. This is not a permanent home for them. So there's what we call warm handoffs, right? So when the patient goes to the personalized care clinic, our team in the primary care clinic actually talks to the care manager and the internist there, gives them kind of an idea of what's going on, what some of those challenges are. They take the patient, they work with the patient, and before the patient comes back, there's another warm handoff, and that warm handoff can include actually the care manager from the primary care clinic going to the last couple of visits within the personalized care clinic so that they are fully aware of what's going on and then transition back whatever plans we put in place or somebody, it's not just a computer screen you're looking at, there's somebody that actually knows what's going on. So, and then the last bullet, the length of time varies. One of the things we didn't do so well, I guess administratively, is when we set up the clinic, our internists actually had the idea that for whatever reason they had to get the patients in, stabilized, improved, and out within 3 months, which was not the expectation, but we didn't do a good enough job of saying, hey, listen, you take these patients, if it takes you 3 months, great. If it takes you a year, fine. If it takes you 2 years, great. As long as you're making progress, it's not a set time in the clinic. And I think when we actually did a better job of verbalizing that to our internists, that actually helped them feel a lot better about what was going on. In effect, when they were functioning under the 3-month thing, they were trying to do too much because they thought, oh, I've got 3 months, I've got to get it all taken care of. And so patients were becoming more overwhelmed because now, of course, they had 10 things to do and they can't even handle 3. So that I think if you're going to do something like this, that's a lesson we learned. Just be very clear that listen, whatever time it takes, it takes.
We'll share what we didn't do right. It's fine.
Yeah, you might as well learn from our mistakes. The other thing, and I'm not sure if we have a slide on this or not, but we talked about the team itself. The other thing is the schedule is set up very differently. So patients come in, and when they're a new patient, they actually sit down with the care manager for an hour, and the care manager goes over their health history,
And the pharmacist.
and the pharmacist. Just try to figure out, okay, well, what are your goals of care? And because, as we all know, I can tell somebody what they should be doing, but if they don't really care about their diabetes, and all they really care about is that, they've got a cat at home that they can't feed, or, they're not going to get engaged in their health. So part of that intake process is figuring out, well, what are your goals? What are you concerned about? And then once that's over, then they meet with the internist. That initial visit with the internist is about an hour and a half. And then as it stands now, when those patients come back, those follow-up visits are anywhere from 30 minutes to 60 minutes, depending on what the internist determines on that follow-up visit. So lots more time. So obviously we're not seeing as many patients. That's another advantage of these patients, that they do take time, and so there's more time in this time.
Can I ask you if you track how many people are recommended for the transition but refuse it?
So Dave will talk about that a little bit in the process. No, good question. And I'll turn it over to Dave.
We can answer that one. So it varies, but roughly half don't want to come. Yeah? That's the way it is.
Well, I can say from my own clinic, right? So when
I'm saying even those that, so there's kind of a couple of phases. I'll show you kind of how this works so we can answer that particular, I know where you're going. So our first phase was to reach out to our own medical group PCPs, right? And say, look, here are 800 patients that meet criteria, and I'll explain what that criteria looks like. Take a look. So we sent, 10 to Dr. Johnson and said, out of these 10, which ones do you want to send us? And he said 3. So there was some clinical judgment based on the data, right? We needed some help to validate because it was just data. And then from there, they had to extend an invitation, and out of the 3, maybe 50%, or in that case, maybe 2/3 accepted. So there's kind of a layer or a filtering that happens before it gets to the end patient, and then when it gets to the end patient, we're seeing probably a 50% hit rate. Phase 2, which we're in right now, so Select Health obviously serves much more than the Intermountain Medical Group, and so they're reaching out to some of our affiliated practices, and also to those who don't have a PCP. So as they look at claims data or we look at the utilization, there's no real record that they have a primary care physician. So their care managers are reaching out to them, and our provider relations representatives from Select Health are reaching out to the affiliate folks. And they're doing that same process, right? They're going through and saying, here are the 5 patients, Dr. So-and-so, that meet criteria. Do you want to send them any of them that you'd like to come? If so, please have a conversation with them and see if they'd like to come and visit us, and let us know.
And I mentioned in terms of physicians worried about losing their patients, it's a little more of a tricky conversation with affiliate providers because they actually work with, they're not employed by Intermountain. And so that's an important part of the conversation that the Select Health Care Manager have to have. Is, listen, we're just going to take care of your patients, and they're going back to you. And so they've been very clear about that.
And they were Select Health was really worried about that, right? Worried about that message, but it's been received really, really well by the affiliate practices. They kind of have the Tim reaction, which is, yes, please take that patient, right? I can't see them anymore. I have to see them for an hour every week, and I feel like I need to take care of them, but I don't have the tools and resources. So most of our affiliate practices are not patient-centered medical homes. They don't have a nurse care manager. They don't have a health advocate, so the resources are just not there. Phase 3, I'm not sure we're ever going to get to. I put it on here because it was part of our original design, but we have so many patients that are identified in that top cost tier here that it doesn't make sense for us from a financial model just to take patients that Dr. So-and-so may have difficulty taking care of, right? So in order for us to make this work, I mean, you saw the expensive infrastructure, right, to take care of these folks. We've got to take care of people that are high cost and those that we have full financial risk for, so that when we bend the cost curve, we actually don't eat it and make it work financially for us. I realize you can't see all of the items on here, but I'm going to merely highlight for you what's on here. So we built a pre-screening report in Tableau based on facility data. So Intermountain Healthcare has a good market share in the market. So we use facility data as proxy because claims data is so slow. So this data gets updated daily, so we can see kind of who's hitting high costs and where they're utilizing. And it's a pretty good proxy. We compared it, we went back and compared it to the claims data, and it was about right. So in here we have the payer, what line of business that they're in. If they're self-pay, meaning they have no insurance, they're here as well. We do a 36-month cost, a 12-month cost. We also utilize a tool, Archimedes Indigo. Anybody familiar with that? It's a shared decision-making tool. If you haven't heard of that, I would highly recommend you look into it. It basically calculates an expected benefit score based on what's going on in vital signs and demographics that have been collected on that patient. So it gives you kind of some sort of predictive measure to be able to say that patient likely has some opportunity based on some pretty simple things that they could change that would benefit their health greatly. Behind this, and it's not on here, we have Optum from United that's also helping us with a little bit of predictive calculations. We use a Carlson comorbidity score, which is really helpful for us too. It kind of does a point system. If you have certain comorbidities together, it's not 1 + 1 = 2, it's 1 + 1 = 4, and stuff like that, depending on the different combinations. And then we take a look at ED utilization in the last 6 months and inpatient admissions in the last 12 months. So we kind of combine all those together, a little bit like the Oakland A's and Moneyball, right? And create a rank and say, here are the patients and here's how they're ranked. From there, this is where we get our data to send out to our primary care physicians or affiliates, or back to Select Health to say, hey, will you reach out to these particular patients?
Does all that calculation end up with a specific risk number, or?
We don't calculate our own risk score, just the rank number. So each of those items is equally weighted, and it comes together to produce a rank. So you may have somebody who maybe not as high in cost, but their comorbidity score is 10, so they may show up a little bit higher on the ranking system. So one other thing that we've had to add, so when we're able to send it to our PCPs, obviously there's a little bit of filtration that goes on there, but even then we noticed that we weren't quite getting maybe all the kinds of patients that we felt this care team could best help. So even after we did this, we would export it and do a quick little chart review before we send it out with our pharmacist or nurse care manager, just to make sure that the patients were really those that we could make a difference with. And so they do a quick review on that before we send out, which has been very helpful. Before, when we were just kind of doing it, we were getting a lot of folks, chronic pain patients, whom we weren't well equipped to take care of, drug abusers who were not well equipped to take care of. Not that we shouldn't, right? And we find different resources for them, but that group of team members that you saw there probably doesn't fit best to take care of them. So I'll give you a little bit of a comparison. This was after, 5 months data, I believe. These are the top 5 diagnoses. A typical primary care clinic on the right-hand side, and then the personalized care clinic here. I'll give you just a second to kind of process that. Yeah, it's kind of a problem everywhere. I think mostly as Tim and I kind of look at this, we really kind of see diabetes, a lot of stuff we don't know, right? Not otherwise specified there as well. Number 6, kind of interesting, sleep apnea, pretty prevalent as well. Weight is an issue with many, and psychosocial, right? That's a big piece of what's going on. In comparison to what you have here, obviously depression still being a big deal on a regular primary care clinic, but not as significant. It's a little bit blurry, but there's way too much information. I think sometimes our team feels a little bit like this, so that's why I put this slide up. We do have long visits, an hour and a half for a new patient visit, an hour for a return. You know, an internist is only getting through maybe 7-8 patients a day, which is a pretty big difference. But the model works, or at least this is how we penciled it, because of the cost savings that they are able to help achieve on some of these patients. So where are we at right now? We've had about 1,200 visits in 7 months, including all of those different providers. Only 75 unique patients, so they're coming to the clinic a lot, which is great. Some of these are phone visits, which has been beneficial as well, and some of them are no-cost visits, right? So if they see our nurse care manager, we're not charging them for that. If they're seeing just the pharmacist, we're not charging them for that. I think the other thing here, we're adding more patients now that the second internist has started with us, but patients are sicker than we thought. So to kind of Tim and the doctor's point, they came to us saying, look, we need a little bit more help to be able to manage this. You look at a patient and you look at the data and you're like, well, 15 problems on the problem list and 30 medications, yeah, that's pretty complex. But when you get that patient in your office, it's a little overwhelming, I think, at times for folks. So it's a little bit, they're sicker than we thought.
So the total panel of patients you're currently serving is 75.
You got it.
You got 15.7.
You got it.
How many patients have exited the program, reaching the goals that everybody agreed to?
Oh, reaching the goals, probably only 1 or 2. We've had a few drop out, just saying they don't want to do it anymore. And others who are okay. And we'll talk about some of that data too. So, some challenges. I was under the naive impression that you only change insurance during open enrollment. Not the case with this population. Many being eligible for Medicaid, right, and then dropping off Medicaid, others being admitted to a SNF, and then it changes insurance in the SNF, and then maybe doesn't get re-enrolled back on. So we had, all kinds of issues like that. The speed of bringing a patient in, so I outlined in 30 seconds what takes weeks and months to be able to do as far as getting somebody in the clinic. So that can be a challenge for us. We talked a little bit about bringing the right patient in that we can help, and we've added a different layer of triage to help us. And we had, Health2 is our electronic medical record and centricity practice management software. We started a new clinic and we started it extremely fast. We went from planning to implementation in 9 months. And that's building out a new clinic space within a clinic. And so extremely hired as fast as we could. If you're going to do this, don't do it that way. Make sure you have somebody internal, right? Somebody who knows your systems, your processes. It just took a lot of work to get everybody up to speed. And we probably moved a little bit slower than we wanted, the first month or two, because we were bringing a lot of people in to train people who didn't know the system. Some successes. So preliminary feedback. So we've surveyed 50 of those 75 from our research team as part of Intermountain. 50% of patients feel they have better health. 80% say they have more confidence that their health care is moving in the right direction. And these are themes, right? These aren't specific questions that are asked. This is just kind of summarized at the end. 70% feeling more engaged in their health care, which we like to see. A common theme was reciprocity, which was fantastic for us. That was kind of one of our goals. So because we care so much, and the team and all the resources, the patient feels as though they really got to do something because we're investing so much in their care. One of the bigger successes was getting patients on the right meds, dosage, and figuring out the medical issues. So our pharmacist, when they do that first intake, he was taking folks who had 30 medications down to 20. just by doing med reconciliation. He'd call the nephrologist, he'd call the cardiologist and say, hey, did you know you guys are giving the same thing and they're taking both of them? And can one of you stop? And they'd say, sure, great, cut it, I don't care. And we just say, well, we'll prescribe it, you don't even need to do it. So he would do all that work, which is very labor intensive, but the patients in the survey said that was one of the most helpful things, right? It saved them on medical expenses, on refills, and then minimized some of the confusion. And we're getting some good feedback from our secondary providers. So this is one that came from a note here that patients seeing a provider in the personalized care clinic, and this seems to be doing wonders for the patient. It was from a cardiologist. So that's just subjective feedback, right, that we try to quantify. It's a new program, so we're trying to do all we can to figure out, is it working, is it not, and what do we need to change. We do have some metrics that we're keeping track of for quality, the unbundled cancer screening, mental health integration, which is our behavioral health component. So we embed that within the clinic so they don't have to go somewhere else for that. And then we've done some surveys. We do have some costs and utilization. We didn't have time to pop it into the presentation. Everything is pretty new. So let me just pull this up real quick. If I can. We are seeing, our research people don't like me to share this stuff, so because it's so early in the process. So we took average utilization for 2012 and 2013, and then annualized 2014. Okay, so there's some less than scientific work here, but we've seen about a 29% inpatient reduction in utilization, about 24% ED reduction, and about a 23% expense trend reduction from the average of those prior 2 years. For the 75 individuals. Yeah, we had some, who were utilizing the ED 120 times in a year. To get them down to, you can get some of those patients down just a little bit, it makes a pretty big difference. Others who were using other services that were more expensive. So that's just preliminary data that we're just trying to keep track of and get a handle on. We know we're going to have to measure this over time. As we looked at, I think Mass General's done some work in this with their Medicaid population, and they saw actually an increase in spending for this kind of a population in the first year and didn't see a savings until year 2, year 3, because they had to invest in a lot of the care. We're seeing that too, right? So there's a lot of patients who, if you look at a 12-month cost, we're spending more than what they were spending in the prior 12 months, but it's an investment, right? We're saying we got to invest and figure out what's going on, get you to the right specialist so that we can get you in control and get the cost in.
But overall, they're still expensive.
But overall, even the ones that we're spending more on, there's the ones that we're saving on, so it's still declining.
So presumably you did some assumptions with this project as far as where you thought it was going to go. So are these numbers that you just shared with us, is that trending in the direction?
Pretty close.
Where you thought?
Pretty close. A little short right now, but pretty close. So enough to likely pay for the model. So we added the second internist now, which we hope will help cover some of those fixed costs a little bit better, and the margin will be a little bit better, and see more patients.
Your return on this is entirely from cost reductions to your overall system.
You got it. Yep, that's how it's going to run. So I think, we're thinking long term, right? How do we go to other payers like Blue Cross in the market and say, here's what we're putting into play. Can you pay us differently for taking care of these patients? But right now we don't need to. We have enough that we have full risk for that are in this category that we're going to probably just continue to do this for now until we can make sure we've identified and solidified we can have the right kinds of patients who are meeting the right criteria, whom we can make a difference with, and then we can pitch that kind of stuff to other payers and say, here's who we can help, who's who we can take care of.
Are the 75 patients, are most of them confronted with copay situations? And does that are you able to play with that at all?
We do. So as a nonprofit, we have a financial assistance program, and if they meet all those requirements, we will help them with copay assistance. And a lot of them do need it, even if they do have commercial insurance or Medicaid.
I have 2 questions for you. What about your patients in the southern half of the state who have a long distance to travel? And what about patients who really can't get out of their home but consume considerable costs?
So we have two things that we're working on right now. So this is happening in the Salt Lake Valley as a pilot. We have a sister pilot that's going on called Community Case Management, which is really remote nurse care managers who are helping and doing home visits, and then also doing phone and helping with resources and getting folks into the right place. As we look to spread and do things differently in some of our other major hubs, we'll probably roll out both of these programs at the same time. So there will be kind of that community case management team that will help maybe those who cannot get into the space, can't come to the clinic, or help identify patients who would benefit from actually seeing an internist versus just helping with social or some of those financial assistant type needs. So as we look at our rural areas, that's probably the model that we're going to go with, is taking what we've learned from these two areas and two pilots, still having a place where people can drive to. So most of the patients, we didn't say that, but all patients are within about 30 minutes of drive time of this clinic. For this pilot or this group, we kind of cut off those zip codes. And as we look to expand and grow, we'll have a little broader net with the remote care management that we put in place to help some of these folks.
And I'll just mention, which you alluded to, but the idea is we're going to have each of the population centers in Utah probably an intensive care clinic or personalized care clinic in, Logan and Ogden, and maybe a couple in Salt Lake and in Provo and St. George, somewhere, southern Utah. So.
And all of our, so you saw kind of the string of clinics, right? So even those in our rural areas all have patient-centered medical homes. So they all have a nurse care manager and health advocate. And we partner very closely with our home health division. So we have a home health agency that is part of Intermountain Healthcare as well. So they're helping us with that. And we have one other pilot that we're doing within the clinic where we've given out 5 cell phones, 5 iPhones. They can only use FaceTime and an app that we've created with a business partner that they can FaceTime us during business hours. If they can't get into the clinic, they can't come, transportation's an issue, they have a quick question, they're going to call 911, they can FaceTime us instead. We try and set up scheduled stuff, right? It can be a little bit overwhelming if they're going to FaceTime all the time, but we have that, and the app also helps send out notifications, right? Did you take your medicine today? Did you go walking today? And then it sends back that data to a web-based platform that's PHI protected that we can take a look at. So we're piloting and testing that kind of stuff right now too, to see how we have a broader impact. Yeah, this is better than what we were going to finish with. So
I think you know some of this from Nancy, but in Maine, we have more like your second model. We have 10 community care teams that are working with care managers, RNs, and also with primary care. You made a decision though to have a fixed ambulatory ICU, separate PCPs for some period of time. I'd be interested why you choose to do your second model even in Salt Lake City. Why you chose to have a second PCP. You go to this other PCP for a while and then you come back. Whereas you could put that intensive care with the care management and the wraparound services and not necessarily. So question number 1 is why did we decide to do a second ambulatory ICU model? And the other question I want to ask is about the role of home visits. Because even in that one, what we found is the role of home visits is huge in terms of really being able to transform people's care.
So to answer your question, we didn't know. That's why we started both at the same time.
we tested both.
So we wanted to know which was actually, what was going to help the patients and what was going to help the overall health system in terms of cost reduction. And we're still analyzing that.
They use the same pre-screening data that we use for their pilots as well, so we're being consistent. And then the idea is that we're just going to compare apples to apples, right? So which one is making the biggest dent? And preliminarily, what we've uncovered here is that each group serves the same population, but does more for one population than another. So there are subpopulations within that high-cost group whose needs are better met in a clinic setting than they are in a remote care management setting. So right now, we as a system are trying to figure out, okay, so which populations are those? How do we identify them in data? And then how do we work together as we roll this out? Because we envision that we'll probably have the ambulatory ICU and the care management in the same region, in the same location, working together and kind of being able to expand the reach of both of their programs.
Like Dave was saying, I mean, the data actually is preliminary, but it does look like this fixed model actually is saving us more.
With these high-risk people, I'm sure you're getting people with oral health issues. I didn't see anything up there around oral health. How are you dealing with that with those patients?
And just connecting them to the resources. So we're getting them into the dentist or finding ways to do that. We have a pretty good, robust United Way program. Yeah, I mean, you can call 211 is the number, anybody can call it, and they'll find a way to get you into a dentist that's participating and providing care on that network, and they'll see them for cheap as part of their community benefit, right? So they're just a community partner, and they'll see so many patients that meet this criteria, if they don't have the financial means to do so.
I know you're trying to get the data for this, but what's your gut feeling about some of the conditions in the population that this model is very sort of?
It would be a little bit guessing at this point, but those who are medically complex, so their diagnoses are complex, and a mental health component benefit most from this clinic. Those who simply don't know how to navigate the system, aren't sure where to go for resources, so they call 911 or they go to the emergency room, are benefiting more from the community case management. Let me connect you to resources. And there's some overlap, but if I had to take a shot today and explain based on what we've seen, that's probably what I would say.
Do you have formalized discharge criteria for this program to transition back into
No. So we're developing it right now. We have a general idea. One of the generalities that we're looking at, right, is both the provider and the patient feel comfortable about the transition.
So it's subjective right now. And the providers, when they have their team huddles, they talk about, okay, where are we in terms of this patient? Do we think they're going to be ready to go back to their primary care clinic in a month, 6 months? And right now it's pretty subjective. The other thing I'll mention, you didn't ask, but I think it's worth noting, there are some patients that, even in this really expensive setting, we're still not helping. And if the team feels like they're making no difference, they actually send that patient back to the primary care clinic, because that, in effect, opens that slot up for someone else where we can make a difference. So that's not really a discharge criteria, but it's something that we learned along the way.
Good use of the resources.
We're not using the resources appropriately if we're not making any difference. And so we'll put them, send them back.
And that's a real challenge for the group, right? Because they get some ownership. They really feel like, they're helping this patient, but if they fall off and we can't do anything for them, it's better for us to bring somebody else in who is engaged, right? Who's answering that survey that they love being part of this clinic and their health is getting better. So, and as we transition people, so the plan is as we kind of subjectively feel that both parties feel that way, we're going to start to quantify, okay, so what is helping us feel that way? And let's capture what that criteria looks like. But right now it's still pretty subjective.
Sorry, I went over here.
Oh, okay.
So I'm really kind of fascinated by the number of visits that the 75 people, it's around 16 in the 7-month period of time you were working at, it's around 16 or 17 visits. What's the compliance with coming to those visits? Those actual visits or scheduled?
Those are actual visits.
And so the other question.
Remember, there's phone data in there too, right? So some of the more formal visits are in phone data. So not all of them are having to come to the clinic 16 times in a month.
So let's call those contacts then. So there's approximately 16 contacts in the healthcare system of some sort during the 7 months. Would there have been approximately the same number prior to that for these patients, but just uncoordinated, would you say? Or through utilization and other methods?
I think it depends on the patient, right? So, I mean, we're not not going to get to it, which is fine, but one of the patient stories I was going to show you is that a patient who, in a 6-month period, went to the ER 75 times. And that was different Intermountain ERs plus ERs in the valley. After coming to this clinic in a 6-month period, she had gone to the ER 3 times. So just kind of an example of the difference they're making.
She's gone to the ED 3 times, which she's come to your clinic 16 times.
Yeah, which is a lower cost setting.
Exactly.
Yeah.
It's a more appropriate visit. So it's not that the touches may be the same. My first answer is going to be I don't know, right? I don't know exactly. But I do feel confident enough saying that the folks that we are taking care of, we may be seeing them just as many, but it's in the right kind of setting, and they're happier about the care that they're getting because they feel like it's the right care.
But what hours are you running?
8 to 5:30, 5 days a week. You know, we started doing a little bit later hours to see if that would help, and we just had more no-shows. So, I don't have the exact number offhand, but you know, out of 8 visits, we'll have 1 or 2 that no-show, and that's probably pretty consistent, I think. But when we had it later, you know, in the evening, it wasn't working. So.
Do you see any pediatrics in your population?
No, it's 18 and older. So 18 and younger, we have a similar clinic it's run at Primary Children's Hospital, and they do a similar thing. They're not using the same data, criteria, all that other stuff, right? But complex children, they're taking care of. They want them back.
What does your after-hours coverage look like?
So at 5, when the phones go off, our internists and PA and psych APRN, they take call, so they rotate taking call. And so they use the answering service for that. And then we have Insta-cares or urgent cares that are spread throughout the valley that are open. Most of them till 9, but we have one that stays open till 10. They utilize those. Usually it's a phone call, right? If they call at 6 and something's going on or something's happening, they'll direct them to an Insta-care if they need to be seen, to try and avoid at least the emergency room visit if that's the case. Many times I just talk to them and they're okay.
I noticed on your team that you have 0.1 FTE CDE certified IB.
Soon to be 0.2.
Okay, and I guess maybe that's what my question is that number 3 on both the intensive clinic and on the traditional patient medical diabetes was in there, 3 just 1 uncontrolled, 1 controlled.
Yeah.
So is that ample? And if yes, great. It sounds like you're moving forward.
We're going to add more. Currently our nurse care manager is also a CDE, so she helps.
Sorry, is that, do you utilize other members of your team? Have they received some kind of training, maybe in diabetes management, so they can help support the patients when the CDE is not available? And then the other question I have is that I didn't notice like a registered dietitian on the team, so is that part of the criteria for your CDE for their registered dietitian?
No. We do have a diabetes center that's a mile away from this clinic, so if we felt like they needed a dietitian more than a diabetic educator, we would send them there. Actually, the educator comes from that clinic. It's actually one that's in our region that we oversee, and so we just have her rotate. And to answer your question about other training, so the RN care manager is a CDE as well. So when the CDE from the visiting clinic isn't there, she's there 5 days a week and is helping to coordinate some of that stuff.
But that's something, I would just say that's something we learned, right? So when we opened the clinic, the CDE wasn't on there, and we just hadn't thought about it. But as soon as those patients started coming through, the internist is like, hey, listen, we've got a lot of diabetes, and it's even though that diabetic care center is a mile away, if we can get some resource here, that's really going to help us. So we made that change, made it 0.1, and now it's 1 to 0.2. So we're trying to adapt and learn.
And the reason I asked you quick is I work for the main CDC, and one of the interventions that we're working on now is some team-based curriculum development for hypertension control and diabetes control. And so we're very interested in seeing what it would look like to engage, say, medical assistants and so on, and providing some of that care for people that would be appropriate within their scope of work.
So I think we have time for maybe one more question, and then I don't know if you have a couple minutes that you can say questions.
maybe a selective clinical rotation for some students, because the more we can help PA students, medical students, nurse practitioner, nurse midwifery students to have the experience of understanding a site like this. So I just would encourage you when the time is right to think of that.
That is on the docket. It was part of the original charter. The team is overwhelmed. So to train one more person, they're like, we can't train ourselves.
But that, we 100% agree, because more people you engage, more people you train,
Absolutely.
it benefits everybody.
And we have University of Utah is right up the street, so.
One more right over here.
I know you spoke to a PEI platform that you all have. I'm really fascinated by how you're getting your team to collaborate with one another, share records, share the patient, talk about your case reviews, and who is your partner for the iPhone project?
Savvy Sherpa. They're kind of our own partner, but part of kind of our R&D department. We share the EMR, so the personalized care clinic is on the same EMR that St. Timothy's Clinic would be on. For affiliates, a lot of that is just transferred through faxing, but we do extend our EMR.
Case reviews, or how you tie up the patient collaboratively to your...
We do, yeah.
Are you talking about the team huddle type of thing I talked about, or?
Yeah, for these 75 people.
Okay, all right. So every morning for 45 minutes, the group comes together, that whole team, and discusses who they're seeing today and what needs to be done, who they saw yesterday and what they need to follow up on, and who is nearing transition and what needs to be done in order for them to transition. So they do that every morning. And then once a month, we have about a 2.5, 3 hour huddle with home health, who comes in as well, and we review a little bit broader, maybe those who are not transitioning in the next 3 months, but maybe 6 months, and those whom home health is making visits to, and how we're coordinating and making sure that they're not generating orders that we're generating, or vice versa. So we do some of that coordination at that time.
I don't have a question, just a comment and an accolade, okay? Earlier this morning, we heard wonderful things about how progressive the state of Maine is. As someone who's worked in healthcare in Maine for a long time, I've looked to your institution for innovative thinking, and thank you for coming and sharing your